up, all my tooth doctors and doctresses? Welcome to another video at the Tooth Factory. Today we're going to be continuing with the pharmacology series for coronary artery disease. We will cover both angina and myocardial infarction as a part of dental pharmacology. Dr. Kanan's put together a beautiful presentation and I, Dr. Rishi, Shah, shall present. Today's overview. We're going to be looking at angina pectoris and just the overview of what is coronary artery disease, or also known as ischemic heart disease. We will explore their meanings and their classifications, as well as classifications of anti-anginal medications. Specifically, we will then talk about nitrates. We always talk about nitroglycerin whenever it comes to angina. Then comes beta blockers and calcium channel blockers, sodium channel blockers, potassium channel openers. Now we will learn why this concept is important in trying to mitigate anginal pain. Then we'll also take a look at a short note on treatment of myocardial infarction, both in an emergency as well as general treatment approaches. And then of course at the end we shall summarize the important drugs and their features, and then we shall share the references of the lecture. Here we go. Angina pectoris in introduction. Basically, the term atherosclerosis comes to mind first. In other words, it is an atheromatic plaque that is basically a plaque of fat tissue, debris, anything that contributes to a clot. Now, this is the evidence of clot here as compared to a normal blood vessel. So it actually attaches to the lining and then it grows towards the lumen. Therefore, it's known as intraluminal clot or atheroma. Atheroma. So it is an atherosclerotic disease of the coronary arteries. This is very important. Which artery? It is the coronary arteries. It's also known as the ischemic heart disease. Ischemia because there's a reduction of blood flow going to the heart and therefore reducing the oxygen supply, causing necrosis, hence ischemia, as it depletes the heart muscle of oxygen that it needs. The atheroma clot can reduce the blood flow. This leads to imbalance of oxygen supply. This is the key etiology of angina and the supply and demand of myocardium, leading to a necrotic stage of the same disease, which is myocardial infarction. So remember, this is the necrotic stage of angina pectoris. The clinical presentation of this physiologic condition is known as angina pectoris. So the clinical presentation is known as angina pectoris. It is basically a syndrome of pain that is expressed in three major forms. So angina pectoris can be measured and associated with three subtitles. We have stable, unstable, and Prinzmetal. There are other names which define their roles and their functions. So a stable angina is also effort induced. So basically you have to work in order to get that angina to be stimulated. It is the more typical, more classical form of angina. Unstable, exact opposite. It happens mainly at rest and unpredictable. Prinzmetal or variant, as the name suggests, variant means something that doesn't fall under this or this. It is random, not associated with any of the above mentioned criteria. It's also known as vasoplastic or rest angina. Vasoplastic and rest angina we shall discuss in the following slides. Moving on, imbalance of oxygen to the heart is presented as stable angina. Fair enough. But then myocardial infarction takes place upon necrosis. That falls under the unstable angina. So it's almost like a arrow of progression, right? So this is stable, unstable, and myocardial infarction. The spasm is caused by the decrease in oxygen supply, leading to ischemic or anginal pain. In other words, it's crushing chest pain. So the term that we want to use is apprehension of death. That's what people feel, as if they're going to die from the chest pain. A typical presentation, normally, it's very sudden, it's very severe, and it's crushing in chest. There is radiating pain to the neck, the jaw, the back, the arms in radiation, which means it's not always present, but when it is, it's probably towards unstable angina. And then dyspnea. Now, dyspnea is out of breath. When you run out of breath because your chest is so tight and it's crushing you with pain, then we're looking at even a further category, which is myocardial infarction. And then there are certain atypical presentation. By the way, fun fact, this is more prone with our female patients. When they get MI or angina, they also suffer indigestion, nausea, vomiting, and diaphoresis. Diaphoresis is basically sweating. And it's women that generally get the atypical presentation. Men tend to have more cases of the typical presentation. As you can see in this diagram, you're looking at popcorn and a couch that is sedentary lifestyle. This is unhealthy fats, pizza, burger, candies, and donuts. And this is bad habits such as smoking and tobacco, which produces tannin, and they all work towards the buildup of an atherosclerotic plaque. This is alcohol as well. So we are looking at things like sedentary lifestyle, diet, and habits. That scares the blood from flowing. Therefore, heart stops working, and we call it heart attack. Now, before we move ahead with the theory portion of the whole lecture, it is very important to discuss preload and afterload because it's concerned with blood vessels in the heart. So what is preload? It is the volume, so amount, quantity, of blood in the ventricles at the end of diastolic, right? We have systolic over diastolic blood pressure, right? BP. So at the end of diastolic, the amount of blood there is inside of ventricles, which means the ventricles are huge, right? Their blood is flowing all the way and expanding the heart. That, before it leaves the ventricles, is known as preload. It is increased during hypervolemia, so more blood volume, regulation of cardiac valves, regurgitation of cardiac valves, and then heart failure. In these cases, preload is highly increased, which means the blood is unable to leave the heart. Awesome. Now, let's talk about afterload. Afterload is the resistance that left ventricle must overcome to circulate the blood. So basically, when this pressure right here on the wall increases, then it must also fight back in order to get the blood out, in order to circulate the blood. That resistance is known as afterload. So the preload presents resistance to the myocardial wall, and that resistance that the ventricle must pump so that the blood leaves the body or the blood leaves the heart is very, very important. So afterload, resistance left ventricle must overcome to circulate blood. It is increased in hypertension and vasoconstriction. Whenever there is high blood pressure, so generally more systolic in this case, or vasoconstriction, that is when afterload is increased because the heart has to work more. So the load that the heart must put to remove that blood from the left ventricle is high, and that is known as afterload. Okay, so now that we have the two terminologies clear, let's move on to angina pectoris' classification in more detail. We already talked about the names. We have stable, effort-induced, classical, and typical angina. These are all the same. So what is it? It is the most common type of angina. It is short-lasting, burning, heavy, or squeezing chest pain. But remember, short-lasting. It can also lead to extreme fatigue, nausea, sweating, present in females. We discussed that. And patient generally has a memory that they're predicting this. It is predictable in nature and pattern. Patients already know that, oh, about less than 15 minutes, it'll go away, don't worry. But less than 15 minutes. Anything above can lead to unstable angina as suspicion. And anything that is a first time angina, you want to consider and treat as if it is MI. Okay, we'll get to that in a few slides. So what causes the stable angina? We mentioned that atherosclerosis or clot obstruction in the coronary artery valves. That's perfect. Reduction in coronary perfusion, which means blood flow. When that is reduced, there is ischemia presented to the heart, and that is generally experienced with activity as demand of oxygen increases. So if you're gone for a sprint, for example, your heart needs more oxygen, it demands for more oxygen. And then if you already have an obstruction or a clot in that coronary artery, then you're more likely to have angina pectoris. What is the treatment? Well, rest. So if you went for a sprint, you want to rest and let it cool off, reduce the demand of the oxygen. Then pharmacologically, you're looking at nitroglycerin. Nitroglycerin is a vasodilator. In our general pharmacology lectures, we'll put the links in the comments section and description box as well. We did discuss vasodilation and vasoconstriction. Please do check it out. If there's an observation for any changes in pattern, then it is a potential for unstable angina that we discussed earlier, such as if it lasts more than 15 minutes, that is a change in pattern. And then we must treat it in the hospital. Okay, let's talk about unstable angina. Between stable and myocardial infarction lies unstable. So it's always volatile. The frequency, the duration, and the intensity of the pain increases. Remember, center is pain. Less effort is required to stimulate anginal signs. So instead of a sprint, merely a jog or a walk up the stairs can lead to anginal pain, and that is unstable angina. Rest angina that lasts 15 to 20 minutes, a new onset, so when you don't have any memory of that angina. Crescendo pain pattern. Crescendo pain pattern is new, stronger, and no pattern. That is crescendo pain. It's new. And then, of course, dyspnea we talked about is out of breath. All of these can signify unstable angina. Clinically speaking, it's also known as frank vasospasm. And we'll take a look at the diagram. Frank vasospasm is about 70%, so less than 90% of clot is frank vasospasm. Then there's 99% of obstruction in the coronary artery. It's 100% unstable angina. It leads to ischemia of the heart and experiences pain with less activity compared to before, and it lasts longer. And of course, we treat it in hospital as an admission of patient, and morphine for the pain is given. 100% oxygen is given through nasal hood. We must supply oxygen to this patient, and then nitroglycerin for vasodilation and aspirin for antiplatelet. Now, oh my God, okay, so these are all new, right? But this is how we remember it, MONA. Whenever we're talking about unstable angina or myocardial infarction, we have morphine, oxygen, nitroglycerin, and aspirin. Now, why all of these are taken? We'll look at it in the pharmacology section of the lecture. So far, let's just discuss the classification. Now we're talking about Prinzmetal, which is the variant type, right? The odd, unpredictable type, vasoplastic and rest angina. So the episodes of angina can occur at rest, as if you're just sitting. Imagine just sitting on the couch and getting a heart attack. That's Prinzmetal. However, the pattern is not recognizable. It's unrelated to the physical activity. You could go for a sprint and nothing happens. But if you're sitting down, all of a sudden you have an anginal episode, and that can be classified as Prinzmetal or variant. And basically heart rate and blood pressure, so anything to do with the heart physically, has nothing to do with this type of anginal pain. So then what's the cause? Well, the cause is 99% or more of a clot that either stays there or dislodges. And now we're moving into thrombus. Thrombus is another term for clot. And when the thrombus breaks, it shoots blood towards the heart and also the thrombus towards the heart. Then what if the thrombus lodges somewhere else in the artery instead of here? So that is an emboli. So we'll take a look at these in the next slide as well. So basically it reduces the blood flow to the heart muscle regardless, right? Nitroglycerin and calcium channel blockers can also be given. Acute coronary syndrome. Acute coronary syndrome. Now this is the advanced version of angina pectoris. It is completely an emergent case. MI, myocardial infarction, and this is death invitation. So it triggers the coagulation cascade and vasoconstriction. Now we're looking at a repair mechanism that our body presents itself with. Now this is going to be in our next lecture in the hematology, and where we talk about antiplatelets and anticoagulation and so on. We'll talk about coagulation cascade. But what it does is basically it triggers repair mechanism. It needs to save the blood from leaving the arteries, right? So it introduces vasoconstrictant. It introduces increase in platelets counts and so on. Now, just a hint here. Do you remember in the previous slide here, we talked about aspirin for antiplatelet action? This is where we need antiplatelet, because if we already have a clot, it is an emergency, and then our body in acute coronary syndrome triggers coagulation and vasoconstriction using platelets. What do we need to do? We need to cut that platelet down. Antiplatelet. Therefore, intraluminal thrombosis can lead to necrosis of the heart muscle, causing myocardial infarction. Myocardial infarction is basically recognized by an increase in serum troponins and creatinine kinase. So remember that. This is important for all exams. Troponins plus creatine kinase. These are markers for MI that is seen in a patient who's just suffered a heart attack recently or is about to suffer a heart attack. So it's a predicting marker. If you have an increase of these two in your blood test, then you're about to get a heart attack or you're prone to getting a myocardial infarction. Therefore, an angioplasty is recommended at the very least. Now, in an unstable angina, there is no increase of these markers, and that's the differentiation. Unpredictable, unpredictable. Increase in troponins and creatine kinase. No increase in troponin creatine kinase. Okay? Remember the difference? Please write that down, you guys. On the ECG, the ST segment can be seen elevated or remain the same. That is another sign of myocardial infarction. So what causes it? As usual, when the atherosclerosis ruptures, there's a partial or a complete thrombosis, or luminal tissue inside the coronary artery. Now we're talking about a clot that has been dislodged, that has been repositioned. There may be multiple clots. When plaque disrupts platelets, they get involved. So when there's atherosclerotic plaque and it breaks down, platelets are invited because they think, oh my God, there's bleeding in the coronary artery. Therefore, platelets get activated, leading to further occlusion of vessels. And that is why we need antiplatelet, which is aspirin. We will take a look at it. But remember, this is not an anti-anginal drug. Aspirin is not an anti-anginal drug. Write that down, you guys. It is a drug that breaks platelets down in severe angina pectoris, also myocardial infarction. And again, emergency case, so hospital care, immediate emergency services activation, 911 in North America. And we follow MONA for the transport. MONA being morphine, oxygen, nitroglycerin, and aspirin. Okay, so that was the classification. Great, I'm glad you guys are still awake, and if you guys are not, take a moment, pause, and we'll carry on again. Angina pectoris diagrams. This is very important. Normally speaking, I want to draw your attention to 50% obstruction. The blood is flowing very smooth here. However, here you'll notice the atherosclerotic plaque, which is intraluminally in the lumen of the vessel. Coronary artery specifically, there is potential for angina. And to be honest, majority of us may even have close to this because of the way that our diet works. Non-pharmacological lifestyle, sedentary, work from home, no cardiovascular exercises, things like that. Then comes frank vasospasm. Remember, we talked about frank vasospasm all the way in unstable angina earlier. So, what is frank vasospasm? 99% obstruction. About 90 to 99% is where there's resting angina that is at risk. So, that is the only thin line that is allowed to pass through, and all the blood accumulates here, and only little blood gets drawn to the heart, and oxygen supply is reduced, causing resting angina. When there is increased vascular tone, for example during exercise, you'll notice that even with 70% obstruction, the exercise will induce angina. So 50% potential for angina, 70% exercise-induced angina, as well as 99% obstruction, resting angina. So far, so good in the pattern? Perfect. Then there's a decreased vascular tone, for example, use of vasodilators, and all of a sudden, this 99% frank vasospasm, or this 70% exercise-induced plaque, because it becomes very toned, the vascular muscle gets toned, or even with 50% resting, normal angina chances, 50% obstruction chances. We have vasodilators that can be used, and all of a sudden the obstruction can seem like it's only 30%. Now that 30% is not really 30%. All it is the vessel dilated, therefore more blood can flow through. Notice the thickness of this blue band that has increased when the use of vasodilators exists. Now the mechanism of action, the uses, side effects, we'll get to that in just a moment. Angina pectoris diagram, this diagram basically just shows us what a normal rest and an exercise state looks like. Right? Conducting vessel, resistance vessel, which is flow that is increased during normal scenarios. Right? Flow is increased. Whereas classical angina, this is the clot that reduces the blood flow, and the flow is not increased during resistance exercises. And then variant is when there's a spasm where the flow is actually decreasing. So normally it increases. In classical angina, flow does not increase. And then in variant angina, flow is decreased. This is the more important diagram. This is the crunch that we're going to talk about. This is the heart's wall, specifically ventricular wall, left ventricular wall, where the blood leaves the heart and to the body, right? This dark area is the clot, the atheroma. Where is it positioned? It's positioned on the coronary artery. So coronary artery is supplying blood using perforating vessels to the left ventricular wall. That's the scenario here. Now, at the very end, there is a 5 mmHg, millimeters per mercury, end diastolic pressure when the ventricle receives the blood. End diastolic pressure. Great. However, when there is an ischemic subendocardial zone, so this light yellow area, which is basically an area depleted of oxygen, hence ischemic. So this atheroma prevents blood from properly flowing to the ventricular wall. During angina, there is something known as the crunch, which is this. And that crunch is because there is a subendocardial, so inside of the heart, sublayer, that is ischemic. And therefore, the pressure at the end diastolic region increases significantly, almost 5 times. And that causes pain. So that is during angina. And then when it relaxes, it's in between attacks of an angina patient. This is known as the crunch. Now let's take a look at treatment strategies. Treatment strategies for angina pectoris. And anti-anginal drugs, they either reverse or reduce the cardiac ischemia. So basically, it tends to increase the oxygen flow to the heart, essentially. However, the atheroma, the clot, the pathology still remains, right? So basically, if this is your vessel, this is your clot, all anti-anginal drugs do is they dilate the vessels. They make the vessels bigger, but the clot remains the same. So when the drug effect goes away, vessel returns to normal and ischemia returns to normal. In order to receive permanent benefit, a combination of pharmacological, which is drugs, non-pharma, which is lifestyle changes, exercise, cardiovascular, HIIT exercise, right? High intensity, interval training, and surgical approach. Now, by surgical approach, we're looking at bypass, stent, right? And things like that, or open heart surgery, heart transplant, coronary artery bypass. These things can be done surgically for permanent solution. In this lecture, we'll talk about drugs that are classified based on their role. One is the classification of drug that stops anginal attack, that aborts or terminates the anginal attack, and those are the king nitrates. Nitroglycerin, also known as NTG, and isosorbide dinitrate. There's also a version called mononitrate. We'll talk about that as well. These are anti-anginal organic nitrates. Drug of choice, guys. Okay. Then chronic prophylaxis. Prophylaxis means preventative measures. Chronic means when unstable or MI begins to occur, what can we use to prevent those or treat them in the middle of it so it doesn't get any worse? Beta blockers, which is also known as beta adrenergic antagonist. So we have a lecture on this. Please do take a look at it in the general pharmacology lectures. Calcium channel blockers, sodium channel blockers. These are well used in today's time. And then there's an adjacent class, which is potassium channel openers. Not needed at all times, but they are a part of the anti-anginal classification, so we will talk about them in the lecture. And then, of course, the myocardial infarction treatment modality, that we have a short note at the end of the lecture to allow you guys to come up with an answer if asked during any exam, or treat during a clinical case scenario, which is fairly common, you guys. So let's take a look at the diagram that we have from our references. Anti-anginal drugs, nitrates, beta blockers, CCBs, potassium channel openers, and other drugs, which is basically sodium channel blockers. Okay, nitrates are divided into short-acting and long-acting. Why do we need that? Short-acting because we need to suppress an attack right away, which is nitroglycerin, right? So this is nitroglycerin. It's also a chemical name of glyceryl trinitrate, nitroglycerin. Then isosorbide dinitrate is sublingual version. However, isosorbide dinitrate oral version is long-lasting, right? You gotta eat it, you gotta go through it. Sublingual bypasses first-pass metabolism. We'll take a look at that when we talk about it in detail. Then the other variation of isosorbide, mononitrate, erythritol, tetranitrate is another one. And these are the other drugs that we don't really need to talk about during dental pharmacology, but they exist in the lecture. Beta blockers, propranolol, metoprolol, and atenolol. So remember that A to M, these are cardioselective. So they work on the heart directly. And remember, beta receptors, B1, B2, generally are in the heart itself. So if you were asked, would you choose propranolol or would you choose metoprolol as a beta blocker used for anti-anginal purposes? My answer would be cardioselective beta blockers only, because we want just the heart to be relaxed, nothing else, not non-selective, right? We don't want both of these. We don't want the lungs affected. So we would want beta 1 to be affected only. Beta 1 is affected by atenolol and metoprolol. Therefore, I would not choose this as the drug of choice under beta blockers. And just a little side note for you guys to write. Then comes calcium channel blockers, verapamil, diltiazem, and amlodipine, and the other one, nicardipine, then nitrandipine, and things like that. The safety pins, basically. Safety pin, I say this because it kind of safeties the blood flow. So safety pin, that allows you to remember amlodipine and nicardipine and so on. Verapamil, diltiazem, very, very important. We'll talk about it during the CCB slide in the following slides. Potassium channel openers, nicorandil, we'll talk about its function, very compensatory function. So not primary, very compensatory. And then other anti-anginal drugs, out of which ranolazine, which is sodium channel blocker, very, very important. Another reference of ours that we used also has a classification that is positioned in a chart format, so that's why this exists here. So in beta blockers, atenolol, metoprolol, very, very important. Calcium channel blockers, amlodipine, nifedipine, very common. CCBs, which are non-dihydropyridines, and the above ones were dihydropyridines. We'll take a look at the difference. All it means is one affects the vessel, the other affects the heart. So we'll take a look at them. Diltiazem, verapamil, we talked about. Nitrates, the king nitrates, nitroglycerin. Isosorbide, two versions, dinitrate, mononitrate, and sodium channel blocker, ranolazine. Hopefully the names are now familiar for the following slides to occur. Now, do you notice we kept saying that aspirin is not here? So why is aspirin not here? Aspirin is an antiplatelet, guys. It is an antiplatelet. When do you need antiplatelet? When there is platelet. So when is there platelet? So think of it this way now. This is a good time to explain this. This is the atheroma that is preventing the blood from flowing. Great. Now imagine this atheroma breaks, right? It breaks. Then what happens? Well, all of a sudden, that atheroma can't just dissolve, right? So it floats and leaves behind a jaggedy wound here. Now this can either go directly into the heart, or it can get lodged at a valve corner, something else, right? So it has its own demise. But this area where the clot is ripped off of, that is an injury, guys. It is 100% an injury. What happens during an injury? We have the coagulation cascade. We will talk about this in our next lecture, but it's basically those factors, those intrinsic, extrinsic, those factors get activated, and ultimately platelets are invited to fix this. When platelets fix it, it's like rough work. It's very dirty, not clean, not aesthetic. So now what happens? We have atheroma blocking this area, platelets blocking this area. That is an increase in block, even more than it used to be. So therefore this is stable, this is unstable. So what do we do with aspirin? We invite it, and then we kill the clot caused by platelets. Therefore we need antiplatelets. Okay, that's why aspirin is not an anti-anginal drug. It has nothing to do with the clot. The atheroma, the lipid clot has nothing to do with aspirin. It is the platelet action that we need to reverse. Okay. Hopefully that's clear, you guys. Any question, please feel free to reach out to us in the comment section or on our website. We have a doubt clarifying session that'll add as a promotion at the end of and in the middle of the lectures starting now as well, you guys. Okay. So nature of nitrates. Let's talk about the kings. Okay. Pain is relieved when blood flows to ischemic areas. Fair enough? The concept is clear. The pain is relieved when the blood goes to ischemic areas. Pain is relieved. Great. Okay, remember this fact. Now we're talking about nitrates and their nature. They affect preload and afterload. Remember in our first slide we talked about preload and afterload? Well, here's the application. Preload, it dilates veins more than arteries. So nitrates dilates veins more, artery less. So where are the veins? Peripheries. Therefore, the blood pools in the peripheral region. It decreases venous return to the heart, right? So think about it, guys, one step at a time. When there is a dilation of veins, there is a reduction in blood flow. Okay, so far so clear? When there's vasoconstriction, there's increase in blood flow. Basically, the vessels tend to pump blood faster. But when there's dilation in the veins, we're not talking about arteries, guys. We're talking about veins, peripheral veins. That's where the blood will pool because it's relaxing, right? It's like putting water through a hose and then putting water through a bucket. It pools in the bucket and hose allows it to go. Hose is vasoconstriction, bucket is vasodilation. Remember, we're not talking about arteries, veins. Okay. Preload is now reduced, right? So less blood reaches the heart into the ventricles, less preload, less heart. So heart works less. When heart works less, there is a reduced end diastolic pressure. So I'll draw your guys' attention to this here. Right here. When blood is reduced overall, then this will decrease in the heart, right? And so it reverses the crunch during an angina. That is where crunch is important. This is how preload works. However, nitrates also have an action on afterload a little bit. It has an action on arteries as well. Okay, there's mild dilation of arteries, slight reduction in peripheral vascular resistance, which is PVR, slight reduction in systolic blood pressure, right? All of that, and therefore cardiac output is also less. Heart works less. But afterload is, remember, the resistance that the left ventricle has to face to remove blood from the heart and send it to the body. That artery, when the blood is sent to organs that is used with arteries, they dilate. Therefore, everything else reduces. Hence, pain is reduced. Now, that is just reducing the heart's work. Therefore, it pumps less blood. Great. But what does that have to do with the pain? The pain is caused from areas of ischemia, right? Well, the third and the most important nature of nitrates is altered distribution of coronary blood flow. Very important. The whole vascular tree, arteries, vessels, capillaries, everything is affected by nitrates dilating blood vessels. So we notice dilation, right? Now, ischemic regions will receive more blood because it's compensated by a reduced blood flow to non-ischemic areas. Remember, arteries send blood out to organs. When they're dilated, they send less blood, but there's still blood volume. Where does that blood volume go? It goes to ischemic areas. It is automatically relocated to ischemic areas and the blood flows there, relieving the pain. And that's where the nitroglycerin sublingual spray, sometimes you use a spray in the sublingual region at 0.4 milligrams in concentration in order to allow redistribution of coronary blood flow. Hopefully that concept is clear, guys. Moving on. Nitrates directly do not affect the heart. Remember that? It affects vessels and the flow of blood. Hence, the heart works less. Cardiac output is less. So not directly. Cutaneous and meningeal vessels of the head and neck are also dilated, and that causes a flushing, so redness in the face. It causes flushing, and because of that, it also causes headache. So the number one side effect of nitrates is flushing and headache, because all the vessels also dilate and all the blood goes into that area where it doesn't need to go, and it causes red face and headache. So remember that, you guys. And then, of course, the splanchnic and the renal blood flow is reduced to compensate for vasodilation. So all the other bodies are also affected. Decongestion of lung occurs because the blood shifts to systemic circulation, so no congestion of the lungs. And then, of course, bronchi and esophagus are also relaxed overall. So what's the mechanism? What happens in the molecular world that the nitrates lead to this? And this is my favorite part because it involves pathophysiology. So, relaxation of vascular smooth muscles. We learned how. Great. Nitrates travel intracellularly. So, nitrates will travel inside each cell, and in there, they convert to nitrite ions. Nitrite ions. Those nitrite ions will then take up a role of nitrous oxide. Okay, nitrous oxide has a very solid property to stimulate CGMP, which is cyclic guanosine monophosphate. It is an enzyme. More so, that is responsible for dephosphorylation of myosin light chain. Oh my God, okay, what does that mean? If you had watched our general pharmacology lectures, you'll notice what the term phosphorylation and dephosphorylation means. Phosphorylation means activate. Dephosphorylation means deactivate. So when there is a dephosphorylation of myosin light chain fibers, then there is vasodilation. So they are less active. Myosin is a muscle fiber. It tends to pump blood, right? In the heart, through the heart, into the vessels, through the vessels. When there is dephosphorylation, there is vasodilation. As simple as that. CGMP is very important to remember. Note, there's also an activation of, sorry, apologies for the spelling mistake, activation of guanylate cyclase. What is guanylate cyclase? Another enzyme. Remember, A's are enzymes. This is also done by nitrous oxide. Its function is to reduce calcium influx into the cell. What does calcium do, guys? Calcium tends to stroke the heart. So it jumps the heart, almost like jump starting a car, where we put the two positive negative cords and turn the battery on. Calcium does that to our heart. It jump starts the heart. Calcium is responsible for the contraction and conduction. Contraction and conduction. However, because of nitrous oxide, a guanylate cyclase is released and they reduce calcium influx, therefore reducing in cardiac output overall. That is how nitrates work. So here's a diagram to show us that when calcium is introduced, there's a channel they are introduced from. We can also use calcium channel blockers there. However, calcium introduced itself, calcium then converts into a molecule that is associated with an enzymatic activity, which is responsible for contraction using myosin fibers. Okay, myosin fibers, great. But how does myosin actually get activated? it is CGMP that interferes in this process. Now, nitrodilators turn into nitrous oxide. Nitrous oxide increase CGMP. CGMP provides a negative action to this myosin light chain kinase reaction and also produces a negative effect towards the calcium influx. Therefore, no contraction. Fair enough? So this diagram might help you guys understand. I would change, if I were writing the notes today, I would just change these into words just so we understand. And if you draw this in your exams, guys, it is ideal in your DDS and BDS classes. Primary uses of nitrates. Primary uses of nitrates are angina pectoris, myocardial infarction. Great. We talked about CADs and IHDs so far, but it can also be used in congestive heart failure, acute left ventricular failure specifically, biliary colic, in other words, abdominal pain. That's all it means. It is caused when gallstones accumulate or morphine-induced abdominal pain. We can use nitrates. Esophageal spasm and cyanide poisoning. Cyanide poisoning because one of the side effects of nitrates, along with flushing and headache, another one is producing methemoglobin. Methemoglobin is actually harmful for our body normally, but it's produced in less amounts with nitrates as side effects. So when it's produced and when somebody's been poisoned with cyanide, you have to take IV nitrate because it has a high affinity for cyanide. The methemoglobin is highly potent to attach to cyanide, making it inactive. It makes cyanomethemoglobin. Cyanomethemoglobin deactivates the cyanide, therefore cyanide poisoning can be treated. Moving on, pharmacokinetics. Very interesting how they work. The onset of action is 1 minute for nitroglycerin, short acting, remember, and 30 minutes for isosorbide mononitrates and 5 to 8 minutes for dinitrate. So this is generally longer acting or long onset of action. Administration, when spray and sublingual is given as nitroglycerin compounds, it is best for fast relief of stable angina because one, they bypass, right? Sublingual bypasses first pass effects as much as we'd like them to. IV does not. So intravenous is for unstable angina, hence longer duration, first pass metabolism, where in metabolism, a first pass liver metabolism, a liver enzyme that is glutathione reductase will digest these compounds. However, sublingual avoids this first pass. Remember that, you guys. Okay. And the duration of action. Duration of action is shorter for nitroglycerin. It depends on the administration. However, an article of the FDA suggests that average of 25 minutes is the duration of action. The effects of nitroglycerin will last for 25 minutes. But it's longer for isosorbide, and it's up to 6 to 10 hours for isosorbide. Here's a diagram that produces the same result. As we, for example, notice that the onset of action is red and duration is blue. Sublingual's onset of action is quickest and duration is 25 minutes. This is for nitroglycerin. And then, of course, the oral and transdermal administration have longer onset of actions and durations as well. Perfect, and same goes for isosorbide dinitrate and mononitrate. Okay, now some important facts and important note pieces about nitrates. There's an interaction with nitrates. Sildenafil. If we don't know what sildenafil is, it is Viagra. Viagra was invented for a very specific cardiovascular purpose. However, its side effect showed vasodilation in male reproductive organ, the penis. What that did was it allowed increase of blood flow to the penis, giving treatment to erectile dysfunction. Okay? Now, why is that important? Well, because it's a vasodilator itself, peripheral, right? It's supposed to be peripheral vasodilator, cylindrical. Therefore, the drug is contraindicated with the use of nitroglycerin because nitroglycerin is also a vasodilator. It causes vasodilation. Therefore, a dangerous potentiation of nitrate action is anticipated when there's combination. So what happens clinically? There's hypotension, myocardial infarction, and death can also occur. These are recorded statistics. And what are the adverse effects of nitrates? Some of them I bet you can name already. Flushing of the face, throbbing headache, sweating and palpitation, fainting and dizziness due to postural hypotension, right? Reduction in blood pressure we talked about because of nitrates, and a little bit of methemoglobinemia. And then of course if cyanide poisoning occurs, this becomes an actual benefit rather than a side effect. Tolerance management. Nitrates can be developing tolerance actually. So blood vessels become desensitized to nitrates. Blood vessels need rest, right? It gets so used to it and our body is so smart that it will get desensitized. Therefore, we need to use something known as nitrate-free intervals. And it's 10 to 12 hours, generally nighttime. But I need you guys to focus on this. When you don't take nitroglycerin at night, when you don't take it, your blood vessels, because of the clot, come back to normal. And when you wake up, guess what happens in the circadian rhythm? Increase in vasoconstriction occurs. Your body needs to get up, right? It needs to begin the work and get it started and pump the blood flow to the whole body. This can get worse. So after a nitrate-free interval, we're going to need a morning dose of nitroglycerin prophylactically. Okay, so remember that, you guys. And that's where aspirin also helps and so on and forth. Okay, so that was nitrates. Now we're moving on to the other class of the drugs, beta blockers as anti-anginal drugs. Beta blockers are a wide range of action, one of them being anti-anginal. How? Well, it follows a concept called favorable redistribution of blood. Remember that. It is where the ischemic areas will receive blood flow in the subendocardial region where the ventricular wall tension is reduced. Remember, we're talking about this guy right here, ventricular wall. We need to reduce this crunch, right? So remember this diagram, very, very important diagram, guys. So beta blockers will work to reduce ventricular wall tension by redistribution of blood into ischemic areas. Perfect. However, does not dilate any vessel at all. Remember, it affects beta 1 receptor. Guess where beta 1 receptors are? They're on myocardium, on the heart. It causes direct reduction of heart rate, contractility, blood pressure, cardiac output, and so on. So remember, nitrates work on vessels, veins, arteries, capillaries. Beta blockers work on heart. Therefore, there's a reduction in overall oxygen demand. So we're not increasing supply. No, we're not increasing the supply of oxygen. We are decreasing the demand of oxygen by having the heart work less. Reduces frequency and intensity of the anginal attacks. How nice is that? Covering both ends at the same time, right? Beta blockers. Anti-anginal use, it's to increase exercise duration and tolerance. And it reduces the risk of MI and death, especially with people who already have a history of angina and MI, who have hypertension, or have had congestive heart failure. Those are the uses of beta blockers as an anti-anginal dose. A specific drug that we need to use, cardioselective. Remember, we discussed this already. We just want beta 1 to be blocked. Beta 2, no problem. Go on, take a look. It's in the lungs and kidneys anyways. So no problem. Keep going. Therefore, a cardioselective such as atenolol, metoprolol, remember the A to M is better than non-selective. And propranolol can also work because it also does block beta 1. But unfortunately, it blocks beta 2 as well. We don't really need it. So atenolol and metoprolol are better beta blockers. For this purpose, caution, when there's a variant angina, beta blockers can make it worse because we don't know the cause. Severe bradycardia, where the heart is already in a reduced state of heart rate, patients are at a risk with beta blockers because beta blockers will also reduce heart rate even further. And just as a little side note from general pharmacology, when you have bradycardia, atropine is used. Remember that. Okay, let's go ahead. Calcium channel blockers as anti-anginal drugs. General information. Calcium, it causes contraction. Okay, very simple. Blocking it causes relaxation. Very, very simple. The myosin fibers in the heart need calcium to function. Great. But during ischemia, calcium influx is increased. The calcium channels that are open during ischemia allow membrane depolarization, the hypoxia. So, in essence, reduce oxygen, increase depolarization of the membrane, which then increases calcium influx, which then causes increase in contraction. Therefore, it causes pain. Okay? Calcium channel blockers protect against that hyperactivity of the myocardium and vascular smooth muscle walls, as well as arterial beds. In other words, nitrates were vessels, beta blockers was heart, CCBs is heart and vessel. Both. Now, if you remember, there were two types of calcium channel blockers. Remember, we talked about the verapamil diltiazem, and then we talked about the amlodipins, right? So let's take a look at where they went here. Calcium channel blockers, we have amlodipine, nifedipine, nicardipine. Verapamil and diltiazem were one family. These are two different families. So one acts on vessels, the other acts on heart. Okay, therefore, CCBs are also arteriolar vasodilator. Remember, nitroglycerin, nitrates, they were venodilators. But calcium channel blockers are arteriolar vasodilators. They decrease the vascular resistance in the coronary artery itself at the head office, vascular smooth muscles, and leading to a decreased blood pressure as well. So, in effort-induced stable angina, CCBs reduce oxygen consumption of the heart, therefore reducing the afterload. Why afterload? Because it's an artery dilator. Remember, what was afterload? Afterload was blood leaving the heart towards the organs. How does it leave the heart? Arteries. It is an arteriolar vasodilator. That's what calcium channel blockers are linked. So all of the notes that we just talked about, the pointers I write down, you guys, please do write them down because they formulate a nice flow chart, a story to help us. A special note to remember, verapamil, it's on the heart. Amlodipine is on the vascular smooth muscles. Diltiazem is intermediate, which means it acts on both heart and smooth muscle. Just a side note. Okay. There are two types, dihydropyridine, non-dihydropyridine. Okay, let's talk about the safety pins first. Dihydropyridines, amlodipine, nifedipine. Right? Amlodipine is primary. It has a high effect on arteries, low effect on cardiac conduction. It can be used to treat variant angina. Do you remember that nitroglycerin can only do venous? So it only kind of deals with the immediate symptoms. Beta blockers could not deal with variant angina, remember? But calcium channel blockers, they can because it affects the coronary artery itself, specifically the dihydropyridines, amlodipines. Nifedipine is secondary. It's when you need an extended release action of the same. Side effects, very similar to the other ones: palpitation, edema, dizziness, and fainting. This is normally due to postural hypotension. Okay, it reduces, right here we just talked about, that it decreases blood pressure as well, and postural hypotension can cause dizziness and fainting. Then comes non-dihydropyridines, which is verapamil and diltiazem. Verapamil is primary. It is high on cardiac muscles and low on the vessels. So this is vessels, this is the heart. It slows the AV conduction. What is AV conduction? A conduction from artery to vein or atrium to ventricle. Now, remember this, guys. AV stands for atrioventricular conduction inside the heart. Therefore, verapamil affects the heart. But there is a diltiazem, which is secondary function to reduce AV conduction and creates vasodilation as well. Therefore, for the sake of memory, AV can also represent artery and veins. Okay. However, remember, AV is atrioventricular only. Okay. It decreases the heart rate, contractility, blood pressure, oxygen demand of the heart, so the heart works less and therefore reducing afterload again. This type of a classification is contraindicated in patients of heart failure due to negative inotropic effect. Okay, so what is inotropic? I'll draw your attention here, you guys. Inotropic is contraction, so pumping of the heart, like the stroke that is felt. And chronotropic is the conduction of the blood through the heart, through the veins, through the arteries, and so on. Chronotropic. What does CCB do? It provides negative inotropic. We know that it reduces contractility, right? Decreases contractility. But in a heart failure case, we need contractility. We need a drug that increases inotropy, increases chronotropy, right? So a patient that is already in heart failure, calcium channel blockers are going to give negative inotropic. Therefore, the strength of the contraction is weakened with CCB. So something to keep in mind. Sodium channel blockers. This is ranolazine, which is a drug of choice in this classification. However, it's fairly new. It inhibits the late phase of sodium current. What's that signify? Well, intracellular sodium and calcium overload is reduced, essentially. Now, sodium propagates ATP signals. Calcium causes contraction. Ranolazine blocks all of it. Hence, overall, it increases the improvement in oxygen supply and demand equation of the myocardium and vascular smooth muscle. It decreases the frequency of anginal attacks and improves the exercise tolerance. So it can be used in chronic cases as well as in arrhythmias. So it's like a side character. Caution: highly metabolized in the liver by the family CYP3A4 enzymes. It creates extensive drug interaction with all drugs that are metabolized by CYP3A4. I urge you guys to check out our drug interaction lecture, and you will know which drugs are metabolized by this enzyme in the liver. It creates extensive drug interactions, we mentioned, and it prolongs the QT intervals on ECG. Therefore, this drug cannot be given with other drugs that increase QT intervals. Okay? Potassium channel openers. I kept stressing in the earlier section of the lecture why opener is so important. Well, normally, intracellular concentration of potassium ions is much higher. It loves living inside the house. It is responsible for depolarization, so activation of the membrane. So basically, when potassium is inside the cell, there is vasoconstriction. That's what it means. So what do we need to do? Open the channels so that potassium leaves and we can move to Vasodilation. Very simple concept, right? So, however, opening the potassium channels deliberately by the drugs causes outflow of potassium, leading to hyperpolarized state, which is inactivation of constriction of vascular smooth muscle in the question. So like nitrates, it acts on the nitrous oxide donor characteristic, where it increases the CGMP. Remember that activity, guys? CGMP. We're talking about this section of the lecture up here. CGMP, this section. Okay, so bring yourselves back to the diagram. Very important diagram, guys. So it increases that activity, therefore it relaxes the blood vessels. No significant effect on the heart, so nothing to do with the heart, only vessel. Drug of choice in this class, nicorandil. It's still a new addition to the family, and decreases anginal frequency, increases exercise tolerance. Side effects, whenever there is a venous dilation, there's flushing and headache, no matter what. In this case, it can cause mouth ulcers. And then, of course, there's palpitation and dizziness that follows as usual, and nausea, vomiting can also occur. Okay, so moving on to the next slide. Where is aspirin in anti-anginal drugs? Well, aspirin acts as antiplatelet, anti-inflammatory, analgesic, correct? But it depends on the dose that it's administered in. In the case of angina and myocardial infarction, aspirin is not the first line of treatment. However, it's a therapeutic advantage that it provides as an antiplatelet production with 160 milligram to 325 milligram chewable tablet. So in this case, this brand right here shows aspirin as an NSAID pain reliever. It's chewable low dose aspirin, 81 milligrams. We would offer to take 2 tablets right away. Right away. Whenever there is MI, take aspirin. 2 right now. Chew it. Okay. What it does is it prevents aggregation of platelets when platelets are invited during unstable angina and thrombus formation. Remember, thrombus is platelet aggregation. Remember, when the clot leaves, there is a wound that platelets tend to seal. And again, we'll learn about this in the next lecture, how it actually happens. That platelet needs to be break, otherwise it's increasing the clot. It's creating a bigger thrombus. So it prevents the aggregation, antiplatelet activity. It improves the blood flow by preventing clotting action, has no effect on the actual muscle itself, vessel, heart, nothing. Just the clot itself. Therefore, it helps indirectly in supplying blood to the heart, oxygen to the heart during ischemic attacks and necrotic stages of myocardial infarction. So later, in stable angina, you really don't need aspirin. Nitroglycerin should be okay in stable angina. Other antiplatelets can also help, right? We have dipyridamole, which is going to decrease the ADP release. What is ADP? ADP is like a signal. It's like a whistle. When ADP is there, platelets follow. ADP is not there, no platelets follow. So this reduces the adenosine diphosphate. Then the thianopyridines decreases ADP initiated platelet aggregation. So ADP may be there, whistle may be there, platelets are invited, but it will reduce the aggregation of platelets together. And what are these drugs? These are clopidogrel and ticlopidin. You'll notice these drugs pop up in the next lecture in detail. Platelet integrin inhibitor. This is another one. What does integrin mean? Bridging. Bridging. That is integrin. That is dealt by G2B3A. What is GP2B3A? It's glycoproteins. Glycoproteins does what? It attaches one platelet to the other. It's like a glue, bridging. Therefore, the platelet integrin inhibitors, things that block the GP2B3A, It blocks that bridging, the glue action between the platelets. Therefore, no platelets can touch each other, so no clot. Simple. And the xemabs, xemabs pop up a lot. And tirofiban is one. But we'll talk about this in the next lecture for in hematology. Okay. Now, myocardial infarction, the short note we've been waiting for, very important note for exams, education, clinical experience, everything. What is myocardial infarction? Ischemic necrosis stage of coronary artery disease, last stage. And then after this stage, it's usually death. Heart attack is something that we call a heart attack. Etiology, acute thrombus at the site of atherosclerotic obstruction. So platelet action, lipid action, 99% and more, 100% blockage. In this case, 25% of myocardial infarction patients suffer from cardiac arrest, causing death before the therapy even can begin. So in an emergent therapy, so in emergency cases, how do you approach myocardial victims? We call 911, we call emergency services now. Morphine is delivered for analgesic of crushing pain right away. Give a dose of morphine right away. Oxygen administered 100% using nasal hood. Nitroglycerin is administered 3 times sublingually, 5 minutes apart for a total of 15 minutes. And then aspirin is given 162 to 325 milligrams that we talked about as antiplatelets, so that the clot, which is the thrombus at the site of the atherosclerotic obstruction, that can be reduced. Okay. Remember MONA, morphine, oxygen, nitroglycerin, aspirin. If you don't remember MONA, now you will, because Mona Lisa is having a heart attack. Right? Mona Lisa is having a broken heart syndrome, so you will never forget it. Her heart is broken. Mona, Mona. I keep saying this over and over again because this is extremely important, you guys. Now, general therapy. We talked about emergent therapy. What is general therapy of MI victims? So what all can be done for MI patients? So for pain anxiety, we talked about morphine if nitroglycerin does not work all 3 times. Okay. Oxygen 100%, great. Slow IV infusion of 2 things. Saline dextrin for BP correction, sodium bicarbonate for acidosis correction. Remember, sodium bicarbonate is soda. That is alkaline. There is acidosis in the body at the moment. To correct that, we give sodium bicarbonate. Okay. Prophylactic IV infusion, beta blockers. Contraindicated with bradycardia cases. Atropine can be given for bradycardia and heart failure cases, heart block cases, to increase the heart rate basically. Lidocaine can be given for tachycardia cases. If there's tachycardia, you give lidocaine. Vasodilators like IV nitroglycerin can be offered. Ionotropes such as IV dopamine and dobutamine, because the heart stops, right? Cardiac arrest. Ionotrope is increase in contraction. So ionotropes like IV dopamine, dobutamine can be given to jumpstart the heart. Aspirin can be given, we know our doses by now, to prevent the thrombus-induced platelet aggregation. Heparin can be given to prevent deep vein thrombosis and pulmonary embolism. This is basically an anticoagulant. So along with antiplatelet, anticoagulant can also be given. And again, this is in our next lecture. This is going to be a full 1-hour lecture, so stay tuned for that. And fibrinolytics, such as streptokinase to allow thrombolysis. Fibrinolytic. Lytic means to break. What are we breaking? Clot. What causes clot? Fibrins. Right? Fibrinolytics, to prevent deep vein thrombosis and pulmonary embolism. Then we have antihypertensive drugs such as the ACEIs and ARBs. which are prevention of congestive heart failure. That they can be used in the prevention of congestive heart failure. Control of hyperlipidemia by lifestyle modification, and this is 100% number one. So diet, habits such as alcohol and tobacco, they need to be corrected. Exercise, very, very important. Okay. And then this is just a treatment modality for stable angina. We talked a lot about unstable angina, myocardial infarction, but stable ischemic heart disease, where guidelines directed medical therapy, including emphasis on lifestyle changes for cardiovascular risk reduction. We talked about diet, habit, exercise. Okay, but when there's anginal symptoms present, what do? We give nitroglycerin for immediate relief. Then we give beta blockers, and if inadequate, we give long-acting nitrates, which is isosorbide dinitrates. Or we can give calcium channel blockers, one of the two, but again, remember contraindications on each end, okay? And then if not, then you finally add sodium channel blockers because it blocks the late sodium channel response. Fair enough? Perfect. And then this chart is where you can pause and also look at the whole summary of the whole chart, of the whole lecture, all the drugs, everything's in here, but this is from the reference itself. We've already summarized everything, but if you'd like to note this version down, please pause, and this is from our reference. Resources for today, as usual, we have Pharmacology by Lippincott, and we used the medical knowledge from Hall, the medical physiology textbook. The links will be in the description box below. Thank you for watching, you guys. Stay tuned for the next lecture. Next lecture will be continuation of pharmacology for blood. We're going to talk about antiplatelet and anticoagulants. Okay, well, thank you and have a great day, you guys.